Bonjour. Let's talk about a very important part of the world of competitive intelligence, which is what people call a landscape analysis. It has multiple names, but one of the terms used is landscape, the comparison within a market, within a usually tumor type, often within the subset of a tumor type, a key population, the comparison of the standard of care for that disease and emerging new standard of care supported by new data. And we're going to talk about how the technology we're building, the solution that we already have, is a new tool that is we believe very valuable. We're going to talk about it with the person behind it, Dr. Judith Perez, who is our head of data science and AI, and she also has been spearheading the landscape feature of LARVOL CLIN. Judith,
Good afternoon,
welcome to
Bruno.
the podcast.
Thank you. Good afternoon, Bruno. And thanks for the nice introduction. So, yes, here
Before
we are.
just
Yes.
before we start, 1 minute of infomercial. The LARVOL Group is a cancer data and AI company. I like to introduce us as a 150 people, 20-year-old startup, and we're building solutions at the intersection of oncology data and data science. In particular for the world of CI, but also for other functions within the life science industry. LARVOL CLIN, which you can find online, and there's actually a trial version available for free. Think about it as the Wikipedia of cancer data. Now back to you, Judith.
Certainly. And today we're going to be navigating within LARVOL CLIN, this section of landscapes that, as Bruno was putting into the words, of a 360 view of that particular key population definition with maybe sometimes focusing on a particular drug or treatment, such as in, for example, let's take the first one. We're going to be exploring first-line advanced metastatic renal cell carcinoma, focusing on IO. So when we get there, in here, we're going to be displaying in a format of a data summary, what's interesting, what are the treatments mostly approved, or what's ongoing trials of interest that are going to be covering that landscape, that key patient definition. So in this case, we have Opdivo, Keytruda, and Bavencio. And in the data summary, we will be having a first view of that comparison across the different trials that do evaluate these drugs. So a first summary instance of the status, the primary endpoint, intervention, and control for those trials. And right below, we have the outcomes for these trials that we are going to be comparing in terms of OS, PFS. So all times thinking about which is the primary endpoint. So which would be the key outcomes that would be of interest, along with other survival rates. In here, we will also be able to trace back which is the original reference to what the landscape, the data was extracted, the data for that landscape was extracted from, as well as even if there's a similar landscape or this is a landscape that needs to be credited from other third-party entities that have also been working on this type of landscapes, we may want to match it and people be able to check it out. I will stop a bit more there. So you can see how the landscapes look like and are fully customizable and curated.
One thing to add to your description is that the benefit of having such a data summary, such a landscape online, as opposed to a PowerPoint or as opposed to in an Excel. Some of our customers are coming, of course, from an Excel and PowerPoint tradition with their landscape. But the benefit of having it online is that each time there is a change, let's say, ASCO 25, there's change in three of these cells, so maybe a whole column of data is now available. We can update it. We add a tag that says new, that would stay there for a month, maybe. An alert can go to people who are following that landscape. And everything is clickable, obviously, to the source, to the reference behind the data. Another thing I want to say is that most of our customers, when they build a landscape, they have, in a way, two components of that landscape. Usually on the left, they have the benchmark, they have the SOC, they have there's a regiment or the regimens in that key population that is the current standard of care, meaning that it is recommended by NCCN, which is, of course, a standard definition of standard of care, and also ESMO, ASCO, NICE, etc. But NCCN preferred category 1 is the strongest level of standard of care. So on the left, we tag the regimen that is standard of care to that status. And we have two other types of regimen in addition to standard of care. We have emerging standard of care, and also we have regimens to watch. So emerging standard of care means that it's not quite yet in NCCN preferred category 1, but we predict it will be, or we expect it will be within, I don't know, 6 months, 1 year, but it will be. We call it, it's like calling an election ahead. It's emerging. It's going to become standard of care for that key population. And then we have a third type of standard of care that our customers often like to see, and we call it typically regimen to watch. And these are standard of care that they're not standard of care yet. They're regimen that might or might not become standard of care, but there is one study, sometimes several, that is practice informing. And that might be a segue to the rating in a second, but it is practice informing, meaning that people don't think that it will across the board change the practice. There will be practice changing, but in some subpopulation or as the data mature, the oncologist that we survey, that we index, feels that it could become a standard of care or a partial standard of care for a subpopulation.
Indeed, building on that, you've touched base a really interesting point, and it's that we are working on a new feature that is going to be included under these landscapes. Let me show you. It's not working yet, but there's a mock-up here that I could show that it's being able to add this tag that would be characterizing or featuring that trial, whether it is practice informing, practice changing, as you were calling out, either negative, so the trial failed on results. It is positive, so it hasn't reached not yet the practice informing or changing, but if there are positive results or comments on that, or not rated, so we are not able to evaluate that. And these tags that will be featuring those trials will be tagged by our analyst using sorry, there we go, using different, the analysis of the abstracts that have been published, the comments that are being tagged by the DOS that we follow also, and even you would be able to check out which was the logic behind that tagging, if it's practice informing or positive. Okay, so which are the key takeaways for the choosing of that tagging? So here you would be able to see them, even the key reactions that are associated to that trial. So this way, we are able also to go a step further onto the characterization of the trials that belong to that initial landscape.
And one clarification, and then you can even show us maybe for ASH, the upcoming data for ASH, sure. The raw material we use, our analysts use to determine the success rating of a trial. But one important point to say that these commentaries in support of the rating are for each disclosure. So each time there is a new presentation, press release sometimes, or article or paper published, our analysts would analyze it, give a few examples of commentary from oncologists on that data, and then in some cases revise the overall success rating of the trial. So initially the trial might be mixed, then it could become positive, then the final OS arrive and it become practice informing or practice changing, or in rare cases the long-term follow-up is bad, and then it goes from practice informing to just positive, or from positive to mix, or in rare unfortunate cases to negative.
Correct. That's a good point. Thank you. And that now let's go to what you were calling out. So the upcoming ASH conference data. Okay.
And that's what I tell our customer is that when we give a success rating to a trial, it's really not our opinion. Our job is to, as you get ready to share that screen, our job is to look at, let's say, ASH, and look at all the high buzz results disclosed at ASH, and look at what we do with a mix of AI and people. We extract the sentiment from all of these commentaries. And then what we do is that we are, our analysts would look at all of these commentaries, read them, look at the mix of positive, practice changing, okay, a few occasional negative, of course, and then use all of that to make a call about what the success rating of that trial should be. And the way we organize our success rating is there are 6 of them. First is not rated, meaning either it's not worth rating because nobody cares about that trial, unfortunately, or there's not enough data to have an opinion about it. Maybe the data has not arrived yet. That's not rated. Most of our trials actually are going to be not rated because they're not important for our users. Then we have 5 rating. We have negative. It's easy, negative, did not meet primary endpoint, super easy to figure out. Mixed result, that's harder. Maybe it met a primary endpoint, but missed a secondary one that is a problem, or barely resulted in success in the primary endpoint, but there's toxicity. So that's mixed. That's not going to be good. It's very unlikely to change anything, and it's viewed as a mixed trial. Positive, it met primary endpoint, right? But positive doesn't mean that it's going to be practice informing or practice changing, right? Now, practice informing and practice changing is when it's so positive that the gap in the improved hazard ratio, for example, or the additional number of months in median PFS or median OS is such that people expect that it will change or at least modify the practice of medicine, right? So these are the 6 ratings that we're going to give for every trial we process.
Certainly. And indeed, let me add one thing that also we will be tagging when new data has come up. So every time we will be keeping track of those landscapes that we are building. And if there's a new data release, that cell will be highlighted. So we are also able to showcase and highlight the new comings of data releases.
Well, that's wonderful. I know we're going to be at the end of the time soon, Judith. I want to tell our audience the following. Well, actually, before we get to that, let's say,
Sure.
Explain a little bit what we have here.
Sure. Well, yes. Okay. So let's move to ASH indeed. So in here under our conference tab, we have access to the forthcoming conferences as well as the conferences that have already happened. And in here, in that first analytics, we have a summary of the top trials that will be having abstracts or released in that conference. So along with this sentiment analysis. In this case, the sentiment would be associated to those comments that talk about those trials that have been made by the DOLs that we track, that they are over 3,000 DOLs. So these would be the ratings that are given to the trials.
Well, the ratings here are the number of commentaries from oncologists about each trial. And of course, what we do next is that we translate, using our judgment, all of these ratings into an overall success rating for the trial, right? But it's not like a formula. It's not like if more than X% is negative, it's more subtle than that. We need to check. Well, clearly, the first trial is negative, right? It's got more than half of them is a negative comment, then neutral, very few positive. The second one is interesting because it's got a lot of people who are talking about practice changing, and that's I cannot read the small font here, but that
EA
one.
for the
Yeah, okay.
one. Yeah.
So it's an
Yeah, but
interesting one, right? It's a rare one because it's got a lot of people talking about practice changing, right? Nearly 30% of them, but it's got 25% of commentary and negative. So it's probably practice informing, or it's just simply positive. Okay, maybe
mhm,
mixed, but it will take studying the nature of the commentaries as opposed to just we cannot automatically derive what the trial is here. Polarics we can probably say is negative, right? Triangle is
probably.
another mixed one, another complex one. If
Correct.
you look at a few below, they also clearly expected to be positive because there's no negative comments, and a lot of
Hmm.
people are talking about practice changing.
Certainly.
Right. So,
Okay.
Judith, we're at the end of our call, and I want
Yes.
to I want to thank you for all the good work that you and your team have done. I want to thank the audience, and I want to say if you're interested in LARVOL CLIN, again the Wikipedia of cancer data, which is a very unique platform. Nobody has anything like that. I can say that very confidently. If you're interested in trying it, if you're interested in getting a demo, uh, let us know or go to larvolclin.com and have a look and reach out to us. Thank you.
Thank you very much.